Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse et Transplantation, and the Österreichische Gesellschaft für Nephrologie, Marcus at Home welcomes Professor Lana Castellucci in Ottawa, Ontario, Canada, to discuss the efficacy and safety of Apixaban versus Rivaroxaban in patients with venous thromboembolism, focusing upon her recently published COPRRA trial. Dear Lana, it's a pleasure to host you tonight.
Thank you very much. It's a pleasure to be here, and thank you very much for the invitation. I'm very excited to share the results of the COPRRA trial.
So, Dr. Lana Castellucci is clinical scientist at the Ottawa Hospital Research Institute and professor of medicine at the University of Ottawa. And she is PI of the COPRRA study that compared Apixaban and Rivaroxaban in patients with venous thromboembolism, which was presented as late breaker at the 2025 ISTH meeting in Washington, D.C., and published in the New England Journal of Medicine a few weeks ago.
So again, thank you for the opportunity to be here to share the findings of the COPRRA trial. And I hope that at the end of the presentation today, I can convince you that COPRRA has ended the debate between VTE treatment safety. I'm presenting on behalf of our COPRRA trial investigators, and I will share more of that later. These are my disclosures that are career time. And really what I'd like to begin with is, why did we develop the idea for this study? And so by way of introduction, we know that venous thromboembolism, or VTE, requires at least 3 months of anticoagulant treatment. And many years ago, the direct oral anticoagulants were introduced. And in the phase 3 trials of Rivaroxaban and Apixaban, which we focused on because those are straight oral agents, and we didn't want to use the agents like dabigatran or edoxaban that required low molecular weight heparin lead-in. So we focused on Rivaroxaban and Apixaban, and when we look at those trial results, which were compared to vitamin K antagonists, what we saw was that, of course, for recurrent VTE events, these were non-inferior. And so that was very reassuring, and these were quickly adopted into clinical practice. And then we also look at complications of anticoagulants. And interestingly, there was an important difference that we identified in bleeding event rates between Rivaroxaban and Apixaban when each was compared to vitamin K antagonists. So for the Einstein trials, we saw that bleeding event rates were actually quite comparable between Rivaroxaban and vitamin K antagonists. However, for Amplify, it was significantly reduced at only 4% with Apixaban and nearly 10% for vitamin K antagonists. And we looked deeper into why that might be. We thought that perhaps it had to do with the different bleeding definitions in those phase 3 studies. There were different eligibility criteria. And really what this led us to look at, of course, is what are the clinical practice guidelines saying? So now we know that direct oral anticoagulants are recommended first-line therapies for VTE in all of the major clinical guidelines: CHEST, ACCP, ASH, ESC, for example. But all of these guidelines were limited in the ability to choose one direct oral anticoagulant over another, and that was because of lack of head-to-head comparison studies. And so really what we were trying to do with the COPRRA trial, and COPRRA stands for Comparison of Bleeding Risk between Rivaroxaban and Apixaban for acute VTE. The aim of our study was to determine whether or not 3 months of Apixaban was superior to Rivaroxaban for reducing clinically relevant bleeding events. And as I mentioned, we really wanted to focus this on a real-world population, something that is less artificial than phase 3 trials, where there's a lot of more strict criteria, for example, more restricted eligibility criteria. And so what we aimed to do here was a multinational study. And this is a really important slide because it highlights a collaboration of Canada, Australia, and Ireland, each of us using our respective national research networks. So for Canada, we used CanVector, Australia, we used FANS, and in Ireland, we used Invite. And each of these national networks is part of Invent, which is, of course, the network of networks. And so a really great opportunity for us to have this multinational collaboration and work together towards answering this important question. One of the things that we did with COPRRA was we developed a probe trial design. We wanted this to be as simple as possible so that nobody was blinded. And of course, with blinding and using placebo, it's more costly. And this was a funded trial through Canadian Institute of Health Research. And so an academic study where we had limited financial resources. And so we used a probe design to minimize those costs. But in order to try and be as close to a double-blind trial, we had blinded central outcome adjudication. And our trial coordinating center was here in Ottawa. So as I mentioned, our eligibility criteria were far more streamlined than in those original phase 3 trials of Einstein and Amplify. And our inclusion criteria were quite simple. Patients had to have acute symptomatic proximal lower extremity DVT or segmental or more proximal pulmonary embolism. They had to be adults that could provide informed consent. And importantly are the exclusion criteria, which is, again, a much shorter list compared to the phase 3 trials. And a very important one is the first one listed with more than 72 hours of therapeutic anticoagulation. We also excluded patients who had creatinine clearance of less than 30 mils per minute. And that's because at the time of the trial design, the direct oral anticoagulants were not permitted down to use of 15 mils per minute. And so again, we were trying to keep in line with what the product monographs at the time said. We excluded patients with active cancer. And again, at the time that we designed this study, low molecular weight heparins were still the anticoagulant of choice for active cancer. And so based on the exclusion criteria from the Hokusai cancer trials, that's what we applied here for excluding patients with active malignancy. And then weight above 120 kilograms is also an important criterion that we had. And again, it was based on recommendations from the ISTH SSC guidance that we should be avoiding use of direct oral anticoagulants in patients above that body weight. And then contraindications to either Apixaban or Rivaroxaban based on physician discretion, active bleeding, known liver disease of child pube B or C, interacting medications, or in persons that were pregnant or breastfeeding. And so this is the overall schema of the study. And at randomization, participants were stratified based on their renal function, and we used creatinine clearance above or below 50 mils per minute. And we also stratified based on whether or not a patient was continuing on antiplatelet agents. And so we wanted to identify how many patients were deprescribed antiplatelet agents. We did not have a limit of single antiplatelet or dual antiplatelet. That was up to physicians. And patients were initially, our first patient was recruited in December 2017, and they were randomized to receive either Apixaban 10 milligrams twice a day for 7 days, followed by 5 milligrams twice a day for a total of 3 months, or to Rivaroxaban 15 milligrams twice a day for 21 days, followed by 20 milligrams daily for the remainder of 3 months. And you can see that during our 3-month follow-up period, the outcomes are listed there. Our primary point that we wanted to follow was a combined outcome of major bleeding and clinically relevant non-major bleeding, both of which are defined by the ISTH. And then we looked at each of those components as secondary outcomes, and all of these were adjudicated independently in a blinded fashion. So we looked at major bleeding, CRNMB, recurrent VTE and VTE-related deaths, and all-cause mortality. Our statistical analysis was quite simple. We needed 2,760 participants to demonstrate a 33% reduction in that primary composite outcome, from 8% in the Rivaroxaban group to 5.4% in the Apixaban group. And the primary analysis was a chi-square test, and we did unadjusted odds ratios with 95% confidence intervals in the intention to treat population. So the definitions for clinically relevant bleeding, as I mentioned, these are definitions that have been long-standing with the ISTH. The major bleeding definition was first published in 2005. And so we've used this for decades, obviously, in our major VTE trials. And so we continued with this definition without modification for COPRRA. And as a reminder, it's fatal bleeding, symptomatic bleeding in a critical area or organ, with examples listed there. And importantly, as we'll see later, bleeding that causes a fall in hemoglobin of 20 grams or more, or leads to transfusion of 2 or more units of packed cells. And then for CRNMV, this definition has been available since 2015. And this is actually a departure from the definitions that were used in Einstein and Amplify. So it does lend itself to some inability to do direct comparison in that way. And these are bleeding events that don't meet the criteria for major bleeding, but they are signs or symptoms of bleeding that were associated with either medical intervention by a healthcare professional, leading to hospitalization or increased level of care, and prompting face-to-face and not virtual assessment by a healthcare professional. So in September 2022, we made the milestone achievement of the 2,000th participant. And for a very simply designed study, you may be wondering why it took that long to get there. And of course, it was the COVID-19 pandemic that really slowed us down. And so we were doing quite well in meeting our target recruitment monthly until March 2020, when many research institutes had to shut down active participation in non-essential trials. And so this really did delay recruitment in COPRRA, but I am happy to say that we were able to complete our recruitment in January 2025. And as you know, we presented the initial findings at the 2025 Congress in Washington. With our 2,760 participants that were randomized, you can see the allocation listed here. So 1,370 were assigned to Apixaban and 1,390 to Rivaroxaban. I'll focus on the Apixaban side first on the left-hand side. So 1,362 received Apixaban and 8 did not for the reasons that are listed there. We focused on those that completed the study. So this is our intention to treat population. 1,345 completed the study, and reasons for not completing this study are also listed there. The 1,345 were in the ITT. And for the Rivaroxaban side, 1,380 received Rivaroxaban with 1,355 completing the study. And again, the 25 remaining patients are listed there as reasons why they did not complete follow-up. So both of those groups went on to the intention to treat population analysis. And in terms of baseline characteristics for each of these treatment groups, they're actually quite similar to what we saw in the major VTE trials. So our mean age is in the late 50s, around 58 years in each group. We had a little over 40% being female. We captured sex at birth and not gender at the time that we designed COPRRA. So all of our information is going to be based on sex at birth. We also captured patient-reported race, and you can see the distribution here. So predominantly white race, some Black, and then the other category captures Asian, Latino, or Hispanic, for example, as well as Aboriginal. And there's further breakdown in the supplementary appendix of the manuscript. We also recorded BMI, and again, very similar between both groups, around 29. And as I mentioned, we stratified patients at the time of randomization based on their renal function and continued antiplatelet use. So we did not have many patients with creatinine clearance less than 50 mils per minute, only about 4.5% in each group. And then for those continuing antiplatelets, again, a small proportion, less than 3% in each group. And so what that tells us is that many patients were deprescribed their antiplatelet agent. And for those that continued it, we will be doing further subgroup analyses just to gather some more information about whether or not that contributed to potential bleeding events, et cetera. And then for the qualifying VTE diagnoses, about 50% had DVT alone, and then the remaining proportion had PE with or without DVT. And we also looked at provoked versus unprovoked. And it was about 76% in each group that had an unprovoked event. This is a little bit higher than what was captured in the other studies. It may be related to the fact that we excluded patients with cancer. Some of those other studies did include patients with cancer ultimately in their rosters, and so that might be part of it. And we defined provoked VTE as for the ISTH recommendations. So looking at patients who'd had major surgery, immobilization, being bedbound for more than 3 days, pregnant or postpartum, for example. And so those were the traditional provoking factors that we included. So now moving to our results. So as a reminder, our primary outcome was clinically relevant bleeding, which was a composite of the ISTH major bleeding and CRNMB definitions. And what we saw here is that in the Apixaban group, only 3.3% had a major bleeding event compared to 7.2% in the Rivaroxaban group. And that was an odds ratio or hazard ratio, as the journal asked us to change it to, of 0.44 with a statistically significant p-value. We also wanted to look at those secondary outcomes, as I mentioned, and again, the journal asked us to change this to hazard ratio for ease of reporting and consistency within their reporting. And again, what we saw in terms of major bleeding events when we look at that breakdown, very few in the Apixaban group, only 5 events, compared to 32 in the Rivaroxaban group. Again, the confidence intervals demonstrate significance, but we were not permitted to report p-values for the secondary outcome. And then for CRNMB, this is what we really expected, where we thought we would see the most difference. And so this was not necessarily surprising to us. We thought this would be the greatest difference. And again, it was a very important difference, but we didn't expect such an impressive difference with the major bleeding difference that is demonstrated here. So 39 events for the Apixaban group for CRNMB and 67 in the Rivaroxaban group. We did not have any fatal bleeding events, and we did not have any fatal recurrent VTE. There were recurrent VTE, approximately 1% in each treatment group, which is, again, a very reassuring thing. And all-cause mortality, again, was similar in each group, with 1 in the Apixaban arm and 4 in the Rivaroxaban group. When we look at the graphical representation of this, this is the clinically relevant bleeding outcome. And I think this really demonstrates what many people have focused on since the study was presented and published. And it's that there's very early separation of these curves within the first sort of 10 to 20 days. You can see that there's early separation of those curves. And many people have postulated whether or not it has to do with the difference in duration of the higher loading intensity between Rivaroxaban and Apixaban. And that may, in fact, be something that contributes to it. One of the important things for me, of course, is that these curves remain separated throughout the entire 3-month treatment period. And so I don't know that we can state that the higher intensity loading period alone is what contributes to that difference in bleeding event rates, because we do see that those curves remain separated. And then when we look at our secondary outcome of recurrent VTE, again, here, very reassuring, 1% in each treatment group, and they overlap quite nicely throughout the entire 3-month treatment period. And so again, reassuring data that these agents are great for most patients. We also had some pre-specified subgroups, and these were based on renal dysfunction, based on different age thresholds, whether or not they continued antiplatelet agents, and based on different BMI strata as well. We also looked at race and sex at birth to see if there were any differences. As you can see from this forest plot, just about everything is in line with the main trial results. Everything is favoring Apixaban to the left of this line. And you can see this gives us an opportunity, of course, to look at these subgroups with more scrutiny in the coming months, so that we can try to delineate if there are any groups where Apixaban is certainly far more favorable than Rivaroxaban, for example. This is a table from the supplementary appendix, which further breaks down the major bleeding events that we observed in the trial. So major bleeding, of course, is defined by ISTH and objectively and blindly adjudicated by an independent group. So as we mentioned, there were 5 events in the Apixaban arm, and these are outlined here. You can see that especially for vaginal bleeding, and this included all female participants. And so the denominator here indicates the number of female participants that could have had a bleeding event. And you can see that that's where the greatest discrepancy lies between these two groups, is in vaginal bleeding as well as in gastrointestinal bleeding. And there were 28 bleeding events in the Rivaroxaban group that resulted in a hemoglobin drop of more than 20 grams or receipt of packed red blood cells of 2 or more units. There were bleeding events that occurred in critical areas in the Rivaroxaban group, and those included intra-articular, intraocular, and one retroperitoneal bleed. And so again, not anything that we saw in the Apixaban group, and we will be looking into further subgroup analyses on these bleeding differences from a major bleeding perspective. And then, of course, we also looked at CRNMB events. And again, we anticipated that there would be more in the Rivaroxaban group. And in terms of how these were classified, this was again done by our independent adjudication committee. And the 3 overall groups from the bleeding definition are listed at the top of the table. So those requiring a medical intervention, those that required increased hospitalization or level of care, as well as those needing a face-to-face assessment or evaluation. And you can see that largely it was a face-to-face evaluation or an intervention by a healthcare provider. And so again, sites of bleeding are listed there. We saw very similar to what we saw with the major bleeding events, is that vaginal bleeding and gastrointestinal bleeding were higher in the Rivaroxaban group compared to Apixaban. And those, it was also shown with more hematuria in that group as well. So certainly more mucosal bleeding that we're seeing with Rivaroxaban than Apixaban. And again, this gives us an opportunity to further evaluate these bleeding events moving forward so that we can try to outline any further characteristics for patients. And then we captured medication adherence as a secondary outcome. And these were questions that we developed as a study team to evaluate this. And these were meant to be questions that evaluated adherence in a similar way, but asked in a different manner, of course. And so when we evaluated this, it was done in an always or never fashion. And we looked at each question separately and then combined them all. These are not easy questions. So for patients who are not very medically literate, this was not something that was necessarily easy to answer. So if I were to design this trial again and create questions like this again, I probably wouldn't ask these questions the way that they're outlined here, because I do think that it was a bit complicated. And so what we saw, of course, is that there is a difference between Apixaban and Rivaroxaban. And we know that Rivaroxaban is eventually a once-a-day medication. And we anticipated that there would probably be higher medication adherence with a once-a-day medication. And that is what we saw. So we saw a 10% difference in the once-a-day medication of Rivaroxaban compared to Apixaban. Again, just an opportunity for us to do some further evaluations and secondary analyses. And so moving on to our discussion, what the COPRRA trial demonstrated is that for acute VTE, Apixaban is safer than Rivaroxaban. So for 3 months of that acute treatment, Apixaban demonstrated superiority compared to Rivaroxaban for the primary outcome. And we saw that all-cause mortality and recurrent VTE events were very comparable between the 2 treatment groups. Our strengths, of course, this is the first prospective RCT comparing Apixaban and Rivaroxaban for acute VTE treatment. The probe design was simple. It allowed us to conduct this study in a relatively less expensive way than a double-blind RCT. And we had blinded outcome adjudication, and we used the Verdict platform, which is part of the CanVector network, that allowed us to upload all the information, and then the adjudication committee was able to do this on their own time and through virtual means. So it was a great opportunity for that. And as I mentioned, we really tried to make this as real world as possible by simplifying our eligibility criteria to enhance generalizability. And of course, there are limitations. So as much as the probe design was helpful for conducting the study, there are some concerns with that open label design. Many people have mentioned that, throughout the time of the COPRRA trial, lots of administrative database information became available demonstrating that Apixaban was safer than Rivaroxaban. Did that lead to further investigation of bleeding events for Rivaroxaban, for example? The way that the bleeding outcomes are designed requires interaction with a healthcare team. So I don't think there's any of that bias that would be included here, but nonetheless, it is something to consider. And then, of course, we only evaluated the first 3 months of treatment, and we did that based on funding. So we didn't have funding to follow everybody for 6 months. And so we acknowledge that all patients, whether it's a provoked event or unprovoked, require 3 months of anticoagulants. And so that's why we censored at 3 months. And now, importantly, we know that there is information for cancer-associated thrombosis with direct oral anticoagulants, as well as for patients with a body weight above 120 kilograms, where direct oral anticoagulants are now commonly used. So in terms of clinical implications, I think importantly what COPRRA demonstrates is that if you are selecting a direct oral anticoagulant for acute VTE treatment, Apixaban should really be the agent that is chosen. Although it's twice a day, that twice a day inconvenience is certainly offset by a more than 50% reduction in bleeding events. And important to recognize that it's not generalizable to other patient groups. So, for example, in the extended VTE secondary prevention group, we don't have any information about that from this data, as well as for cancer-associated VTE. We can't make that comparison there. And we have an ongoing trial in the AFib population that's looking at the exact same bleeding outcome between those two groups. And so in conclusion, for acute VTE, 3 months of Apixaban was demonstrated to be safer than Rivaroxaban by the COPRRA trial. And we do anticipate that COPRRA will change practice moving forward and ultimately be incorporated into clinical practice guidelines. And so with that, I do want to acknowledge our enormous group of investigators and collaborators. As I mentioned, this was a multinational study, and everybody contributed greatly to seeing through to the success of the COPRRA trial. All of our patients, our patient partners, their family members, we had a great deal of input into completing this trial, and I'd be remiss if I didn't thank everybody for that. So with that, I thank you and happy to move on to discussion.
Well, thank you, Lana. What an excellent, terrific presentation of these excellent data. You already mentioned so many of the points that we beforehand thought about asking you, so that there's little left. Thank you, first of all. I mean, this is, as you said, an academic trial throughout the COVID pandemic. We saw a lot of trials failing in that period, and you mastered to get the patients together, to have them adhere to therapy. I mean, it's really a great job to be done. And then something that we were all waiting for, we have the 4 anticoagulants, direct anticoagulants, and now there's finally a head-to-head comparison. So I think this makes it very, very valuable. Gunnar said that earlier already. From a cardiology point of view, obviously, but I think we'll have to postpone this to the COPRRA AF trial. Then I would wonder how this all fits to AF, just if you can speculate on it, and particularly the dose thing, and that goes further. You mentioned the 2 times 15 milligrams, but then we have the issue that all the following Rocket AF, Rivaroxaban and atrial fibrillation, every single Rivaroxaban study, prospective study, sponsored, initiated a trial, was done with 15 milligrams Rivaroxaban daily, and not 20, which is used in VTE and also used in Rocket for AF, at least as long as renal function is above 15 ml per milliliter per minute. So I wonder, is the 20 just a wrong dose? Would it all be different with 15 in the long run? This is all speculation, I know that. And in that same way, adherence, you basically answered it already. For us, I mean, the VTE patients sometimes are mostly younger than our atrial fibrillation patients. So in these cases, a single drug, one times a day really does make a difference. And obviously, if you don't take a pill, you don't bleed. And if you have low rates of recurrent VTE, would that make a difference really here, do you think?
No, absolutely. These are all great questions. And, it is obviously something that in the COPRRA AF side of things, we are using 20 milligrams as our standard dose and only doing that dose reduction if they have clearance less than 50. And so it is a question. Is it something in the drug itself, or is it that higher intensity loading dose? I tend to think that it's probably something in the drug itself, just based on their findings from the VTE study, where those curves remain separated. And for COPRRA AF, we're going to be following for a year, so we'll have even longer follow-up to see if there's any changes in that pattern. I do also think, though, that the 15 milligrams, I think that's probably the pharma companies recognizing that maybe in addition to antiplatelets, which a lot of their other studies then went on to add antiplatelets. And so I wonder if that was also part of the rationale for doing a dose reduction to 15 milligrams. Hard to know. But something that we are capturing as well as antiplatelet use in AFib. So yes, I think there's still lots of uncertainty there. In the AFib population, you bring up a great point. They're older patients, they're multimorbid, and so they're often on medications that are twice daily anyways. So I don't know if the adherence component will matter as much in that patient group as it does in the VTE group. So I think that'll be an interesting finding to see if there is in fact a difference. Even if patients are on a once-a-day beta blocker, for example, sometimes they're on a statin, which they often take at night anyways. So the timing of drug doesn't necessarily make a difference, because there's morning and evening times that they're taking different once-a-day drugs, if that makes sense.
Yes, I also have some questions. So maybe it's an obvious question, but do you think there is a real big remaining indication for Rivaroxaban? Is there any cause that we should use this medication, or maybe in 5 years we don't need it anymore?
Yeah, no, that's a great question. I think there are still patients that have not had any similar studies using Apixaban, and I largely lean towards the peripheral arterial disease group, where all of those studies have been done with low-dose Rivaroxaban, and nothing has been done with other direct oral anticoagulants. So I think that's still a niche area for Rivaroxaban at this point. Not to say that perhaps somebody may not, put them on a different direct oral anticoagulant, but I think that's still the area where Rivaroxaban largely owns that patient population.
And I think you mentioned before, but what kind of subgroup analyses are planned? Because we see there's some provoked and unprovoked VTE, or some like CKD patients. Is there something in planning, and can we wait for the results?
Yes, absolutely. So we do have many plans for evaluating all of those different patient groups that you mentioned. So those with renal dysfunction, those that continued antiplatelets, provoked, unprovoked, also looking at any regional differences. So because we had the 3 countries, seeing if there's anything different between Canadians and Australians. And so, yes, lots of opportunity for secondary analyses, just to see if there is a particular threshold that we can identify further.
You mentioned the reasons why you did not include patients with cancer-associated thrombosis and patients with low kidney function. Now, Carolin and me, we are kidney doctors. So in clinical practice, we surely have these patients each day. And we have really the great challenge that neither Rivaroxaban nor Apixaban are scheduled to be reduced in venous thromboembolism, whereas they have these dose reduction in atrial fibrillation. But anyway, if we would speculate, we would expect that the bleeding issue becomes even more important in patients with either cancer-associated thrombosis or with very low kidney function, because these people would really have a higher risk of bleeding than, say, the regular patient. Would you agree to that?
Yes, absolutely. It is certainly a limitation that for at least the early phase of acute VTE treatment, there is no dose modification. And of course, I think the biggest concern, especially in those with CKD, is that that first week of the 10 twice a day. So when I have patients with marginal renal function, I may actually use a low molecular weight heparin for that first week and then put them on 5 twice a day. We have, lots of great information now from the Venous study for dose reduction as well. So I think that's a very reassuring thing that there is opportunity there to get them through that first 3 to 6 months of anticoagulants at the standard dose and then do a dose reduction. And for those with renal dysfunction and borderline clearance, maybe do that dose reduction earlier than the 6 to 12 months, maybe, push it to 3 to 4 months and closely monitor them.
We sometimes switch to edoxaban in these cases because edoxaban has the option to reduce the dosage even in the indication of venous thromboembolism, which makes it somewhat particular. So for us, that's an alternative. I have one more actually observation rather than question, and then I turn back to Stephan. So what is really striking in your subgroup analysis is the very high bleeding risk in patients who are on aspirin or other antiplatelet agents. And we learned from a couple of studies last year, which we also discussed here at Marcus at Home, that the bleeding risk is really sky high in patients on a double antithrombotic treatment. And if I remember the figures correctly, you had, I guess, 35 patients with Rivaroxaban and aspirin, and 9 out of these 35 had bleeding events. So again, underlying that the combination should really be avoided in virtually all patients, maybe with the exclusion of acute coronary syndrome. That's actually more a commentary than a question from my side.
Yes, no, absolutely. Very important to really evaluate and deprescribe when you can.
But I was going to ask that also, we don't have the data yet, which were the patients that had ongoing antiplatelet therapy, or if there were any that had antiplatelets included while on the drug in the study. We don't know that yet, do we?
No, not yet. We've not had a chance to analyze that yet. Because in part, what I want to know is what if they did bleed, what were their bleeding event sites as well, the location of bleeding. Because obviously that antiplatelet effect on mucosal bleeding, if it is GI, GU, vaginal bleeding, then makes sense. But if it's one of those intra-articular or intraocular that we saw, or even retroperitoneal, that's obviously of more concern too.
And just maybe to come to the end, just to speculate, what do you think? Because we saw a lot of data on ongoing ongoing therapy with the DOAC in low dose, even after the 3 or 6 months, and we see very, very low bleeding risks there. And we have excellent data with the low dose Apixaban dose, also 2.5 milligrams twice a day. I mean, this is mere speculation, I know, but do you think there would also be there's a still role for Rivaroxaban 10 milligrams? I see quite a few patients on long, several years, 10 milligrams Rivaroxaban as a single day treatment. It's easy.
Yeah.
I know that you didn't test that, but what's your feelings on that?
Yeah, no, I think you raise a great point. I think we still use a fair bit of Rivaroxaban. My patients that I've had on Rivaroxaban for years, I have not switched them to Apixaban. We don't know whether or not now, years later, does switching them to Apixaban matter. If they've done well, they haven't had any bleeding events, we talk about staying on Rivaroxaban and not modifying that treatment plan, and most are very accepting of that. I think where Rivaroxaban also still has a role is in orthopedic surgery and post-prophylaxis for total knee and hip replacements. I think that once a day option is very appealing for that patient population. There's obviously ongoing studies looking at whether or not straight to aspirin would be an option as well. So that information is yet to come. But for right now, we're still doing 5 days of Rivaroxaban followed by aspirin in many patients post-orthopedic surgery. So I do think that there's still a role for Rivaroxaban in that patient population as well. I think, it's again, what we call that shared decision making with your patient and talking about their fears of hearing this new information come from the COPRRA study. I've had lots of patients since COPRRA was published, they've contacted our nurses saying, should I be on a different blood thinner? You know, and I think that's something that we're going to see moving forward for the next few months, that people are still hearing this information and wanting to know what's best for them. So I think there will be a lot of those individual conversations and shared decisions. Yeah.
Perfect. Well, you answered so many questions already, and then to our questions as well. Thank you so much. And we also learned a lot. We also learned that there's so many things to come, and really, obviously, from a cardiology point of view, looking forward to COPRRA AF. And I think your data really changed our practice. So thank you for your work. Thank you for taking the time to have this interview with us. I think it will be very valuable for everybody. Thank you.
Thank you very much for having me.